Hello everyone. I am going to discuss about a segment in chapter number 311 that is about anemia in chronic kidney disease patients. We know that anemia is almost universal when it comes to stage 3 or stage 4 of CKD because of numerous reasons such as decreased erythropoietin levels, poor absorption of nutrients required for erythropoiesis such as iron, vitamin B12, folate, etc., chronic inflammation and excessive parathyroid hormone leading to bone marrow fibrosis. So these might be the reason for anemia in CKD patients. It will be usually normocytic, normochromic picture. And it is very important to treat anemia in CKD, keeping a target hemoglobin of 10 to 11.5 gram per deciliter. Because if we don't treat it, it might adversely affect heart health, cognition, and also increases the risk of infections in these patients. So how to treat? We have three options. First one is blood transfusion. Second one is erythropoietins. Third one is iron supplementation. When it comes to blood transfusion, there will be increased risk of infections, and by repeated blood transfusions, there might be iron overload. Also, it might be problematic for kidney transplantation in future because of alloimmunization. Next option we have is using erythropoiesis stimulating agents such as erythropoietin. But we know that this might increase the risk of cardiovascular events. So we have to balance the risks and benefits. To show the results very efficiently using erythropoietin, we need to have adequate iron stores as well as some cofactors required for erythropoiesis such as B12 and folate. So we have to make sure that the patient is having adequacy of all these things. And here comes iron supplementation. We can use IV as well as oral. But the important thing here is we have to ensure adequacy of these nutrients in the body by checking transferrin saturation for readily available iron source, also serum ferritin level as a reflection of iron stores. The overall point is we have to make sure that there is adequate nutrients like iron, B12 and folate. So we have to supplement them without fail. Then we can utilize erythropoiesis stimulating agents such as erythropoietin, keeping the potential risk of cardiovascular events in mind. Or we can go ahead with blood transfusion with due impacts of iron overload, infections and alloimmunization. Hope it helps in your clinical practice. See you in next video. Thank you.